Thanks, Alex. Good to see lots of fellow toxicologists here. Let's see. I'm going to share my screen. A second here. All right, how's that? Good?
Looks good.
All right,
Perfect.
cool. All right, well, thank you guys so much for having me. As Alex had said, my name's Peter. I am an emergency physician based up in Boston. And thanks for having me. So, some disclosures for the work we're about to discuss today. I guess as you know from the topic, I've done a lot of work around kind of leveraging different types of sensors to detect disease change. And one of the things that we've been really interested in over the past several years is understanding a little bit more about the physiology associated with an opioid overdose and really thinking about harm reduction amidst the opioid epidemic and where potentially new devices could play a role in the future. And so I talked to you about a project that we've been working on over the past several years to develop an implant to autonomously detect and reverse opioid overdose. And so I probably don't need to tell all of you about the opioid epidemic since you have the world's leading experts in it here in this call. But as we know, this epidemic continues to wreak havoc across the United States. Um, we're in our third-ish wave, I guess, of the emergence of multiple different kind of, I guess, featured opioids. Starting from, a lot of this was driven initially in the early 90s by oral opioids that were prescribed and transitioned to injection heroin use. And now the rise of synthetic opioids, most commonly illicit fentanyls. And this problem, as Dr. Love here knows probably the most about, is complicated by different adulterants that we are now finding that kind of make their way in and out of the drug supply that kind of complicate our ability to care for these individuals. And so here in the bottom, I put a nice theoretical framework to kind of think about the opioid epidemic and our cascade of how, ideally we would want to manage these patients. As we all know, there are several pillars that are important. Obviously, we want to prevent initiation of misuse and use disorders. But for those who have opioid use disorders, we know that there are effective pharmacotherapies to treat opioid use disorder, namely buprenorphine and methadone. But I think the thinking over the past several decades has really changed from complete abstinence to really meeting people where they are and thinking about the disease of opioid use disorder as a continuum. And so some individuals may have a goal of using less, not completely stopping use. And part of, I think, our job is to think a little about harm reduction as well. And so there's been lots of efforts to provide naloxone to the communities. And we'll talk a little bit about some of the efforts there and kind of maybe where these devices could probably play a role, but focus mostly on harm reduction today. The opioid overdose toxidrome or the opioid toxidrome kind of, when you think about it, lends itself very well to a sensor-based solution because there's a characteristic series of events that occurs when an individual overdoses on an opioid. Um, that for clinicians is relatively easy to recognize at the bedside, complicated, of course, by co-ingestions and different other concomitant drugs that people are on. But when we think generally about an overdose, an opioid overdose, are some hallmark features, right? We have pinpoint pupils. We know opioids affect respiratory drive, and so you have respiratory depression, and that can kind of fall into the onset of respiratory arrest. And over time, as you are not breathing, the onset of hypoxia occurs. Those are relatively easy markers for us to measure when we think about these clinically. And the other kind of advantage is there's tons of wearable devices in the market that are available commercially that measure these parameters. If we think about Fitbits, Apple Watches, Android kind of smartwatches, a lot of things have kind of the ability to measure physiology. So theoretically, the use of a wearable device or some type of device could really help us detect this overdose event. And then the other nice feature is that we have a really nice antidote that works really well, right? Naloxone and now, controversially in the market, nalphamine are two mu opioid antagonists that work really well to reverse the overdose event. So when you think of it, we have a pretty decent setup to develop a system that can detect a physiologic change in individuals who overdose, but also potentially provide antidote at the moment that those individuals need. Um, and so, I guess the question is, now that we've increased the penetrance of naloxone into the community, we're providing improved kind of reduction in stigma and treatment. Why does overdose and death from overdose continue to occur? And there's multiple reasons for that. One is that individuals who use may use alone, even though a lot of the counseling has been using with a friend. So those who use alone in overdose, especially those who are exposed to fentanyl, which is the increasing majority of patients that we see, may experience respiratory arrest quickly. And even if they do have naloxone available, who's going to administer it? Um, the other part is that we can't really discount the stigma surrounding opioid use and substance use disorders. There's concerns from bystanders or friends of the individuals who are using to administer naloxone. And finally, the timing is important, right? We know that individuals who experience non-fatal opioid overdose, the majority of them will experience some sort of tissue hypoxia. And the prompt administration of naloxone can reverse this hypoxia and save a life, as we all know. This is some work from colleagues in Philadelphia. This is Alexis Roth's work, if you're not familiar with her stuff. But this is a survey in Philadelphia of individuals who inject opioids, and they were interested in kind of understanding now that we know that the physiology we could detect with a wearable device. Would individuals who actually use opioids be willing to wear something to help detect and potentially reverse overdose? In this kind of single city setting, it's interesting that, there's kind of a trend towards individuals who would want to have a device that senses overdose, potentially monitors your vitals, alerts first responders, maybe even provides naloxone for reversal. But the issue is there's not a lot of acceptance of wearable devices. They're hard to wear. There's stigma associated with them. There could be non-adherence and people may take them off. There's some data that suggests that individuals who have substance use disorders actually will be willing to wear these wearable devices, but still the question of adherence kind of remains. And so because of that, there have been kind of there has been a lot of work in developing a wearable or a semi-implantable device that can kind of feature this closed loop system. So here are some devices that have been recently published, and you can see they're still quite large and kind of challenging to wear all the time. But essentially, the ability to use kind of existing sensors to measure a change in physiology, and then based on that, have antidote available to administer. There are challenges to these systems. So most of these systems are measuring a single physiologic parameter, most commonly respiratory rate. And as we know, there are a lot of medical conditions that might mimic opioid overdose, right? So for example, sleep apnea, benzodiazepine overdose, all cause decreased respiratory rate. And so the chance of a false positive is high. And for these closed loop systems, I think once a false positive is detected and naloxone is administered, you've probably lost that individual from wearing that device again. Because they're semi-implantable, the form factor, I think there's still a lot of innovation to be done around the form factor, and adherence to the devices remains a challenge. For most of these systems, they administer subcutaneous naloxone, and so the delivery of drug tends to be slow over several seconds for these individuals, and we know that every second counts in the setting of hypoxia. And then I think one of the challenges for these wearable devices and semi-implants is that the power budget really limits the usability of devices. And so the ability to sense oxygen or respiratory rate uses very power-hungry sensors. And that really limits the ability for us to kind of detect overdose over long periods of time. And so when we think about that, I think based on the previous work, there are some kind of boundary conditions or requirements for a closed loop system for opioid overdose. We want one that accurately detects the overdose event, and we want to be able to distinguish it from mimics. Because we want to be able to use whatever kind of parameters that detect the overdose to essentially administer antidote, which is naloxone. And we need to be able to rapidly administer it into some type of tissue. Likely, if you're thinking about an implant, which we were, it probably would be the subcutaneous tissue, given the amount of kind of the challenge it is to have an implantable device that administers something intramuscularly. But that is a potential. An implant might, maximize adherence because it's implanted in the body. You could probably still take it out, but it would require a lot more effort to do so. And ideally, you develop a device that integrates into the cadence of clinical care. So not a device that lasts for 24 hours or a week, but potentially thinking of, monthly visits or weekly visits in people who are newly initiated on buprenorphine who may be at highest risk of overdose. We have to start to think a little bit about how these devices might integrate into clinical care. And so our concept of this was, the way that naloxone is commonly used currently is that, an overdose is recognized, and then a bystander or somebody using with the individual kind of recognizes the physiologic findings or the signs and symptoms of overdose. If naloxone is available, it's administered, and hopefully that individual recovers. And so could we essentially take that bystander and make them into a device and implant them in the body of an individual who uses opioids and use the same kind of concepts and ideas to recognize an overdose and effectively and efficiently deliver naloxone in the setting of a confirmed opioid overdose. And so that inspires kind of the device that we've been developing over the past several years that you can see here. I'll show you some more schematics, but essentially this is a small implantable recorder that has similar kind of form features to other implantable devices. So these are common loop recorders. This can be implanted subcutaneously. It's not immunogenic. And there's several kind of components of it. And so we thought about common things that we would want to measure in an individual who overdoses. So thinking about oxygen saturation, ECG, respiratory rate, potentially temperature. And so those are the pieces that the sensors that got integrated into the device. You see a lot of the footprint is taken up by a drug delivery system, which I'll touch base on. And then we really wanted to have a power supply. And because it's an implantable device, we wanted a power supply that could be easily rechargeable that sits in the cadence. And so one of the things that we thought about was a wireless kind of recharging system, similar to how you might charge your phone these days with contactless charging. The system, as I said, it was inspired by a loop recorder, and the implantation is also inspired by a similar fashion. So this is in kind of the bottom panel, you can see here, this is the device with a integrated into a custom-made trocar. And of course, these are my beautiful hands, but making a small kind of incision on the skin, you can bluntly dissect with the trocar and basically inject the device and suture it closed and create a subcutaneous pocket with a implantable, essentially, recorder for opioid overdose monitoring. So great, we made a device. Now we have to test it and make sure that we didn't spend a lot of time to develop something that doesn't work. And you can't test it in humans, we learned. And so the obvious kind of model to do this was in a large animal model. And so we chose a Yorkshire swine model. These pigs are commonly used for human physiology because their cardiovascular system is very similar to humans. I will say that we learned over time that the Yorkshire swine does not have similar vital capacity to people, which became an issue for us as we started to test the setting of opioid overdose. based on kind of some ethical issues, we elected to do this on animals in our lab that had other ongoing experiments, but as they kind of exceeded the weight limits for their holding pens, they would be sacrificed. And so during this terminal experiment day, we integrated into terminal day where we were able to implant the device and overdose the pig under sedation. So these pigs were sedated with isoflurane, ventilated at 100% FiO2 to allow them to survive the event, and other ongoing experiments during that day. We'll talk a little bit about kind of the artificial nature of that because obviously people who overdose are not maintaining 100% FiO2. And we were finally able to kind of change some of our kind of protocols to allow us to do some room air experiments. Um, we use fentanyl, given the prevalence of fentanyl within the opioid supply across the US. And based on the anesthesia literature, a 4 to 6 microgram per kilogram push via central venous axis was thought to be a dose that would reliably induce rapid overdose. Although, that was our best guess based on the available literature. And as I said, the implanted sensor had an ECG sensor in it, a PPG, which is what senses oxygen saturation, and an IMU and a temperature monitor. So the IMU is a accelerometer, and based on the accelerometry, we can get respiratory rate. And as you'll notice, we had some redundant sensors that can sense multiple of these physiologic parameters in duplicate. And that was one of the things we really wanted to do because, first of all, the sensor is implanted, and so there's kind of noise from manipulation from the outside, but we were pretty cognizant of existing attempts where a single parameter like respiratory rate or SAT or heart rate was used, and we really wanted to mitigate the potential for false positives. Um, Finally, for our drug, we developed an ultra concentrated form of naloxone. Because the drug reservoir only holds 1,000 microliters or 1 ml, we had to concentrate up to 10 milligrams of naloxone. So it would be a single reversal event per device. And we'll talk a little bit about that as well. And we did some PK work to demonstrate that 10 milligrams of sub-Q naloxone injection is similar in terms of its area under the curve to IV naloxone. And so let's look at some data. Overall, we did this is about 30 pigs worth of experiments over several years. And what we started to notice is that, so these are all pigs who are intubated, sedated, maintained. These are all at a FiO2 of 100%. So they're on a ventilator. They're on volume control. So these pigs have spontaneous respiration, but if they overdose, they stop breathing and the vent does not breathe for them. And we started to see that there essentially were two groups of animals that started to separate out. And this panel A is probably what we are used to seeing. So you'll see on the top line, this is heart rate, and the bottom, this is the respiratory rate. And this black line here at time 0 is the administration of fentanyl. And you see that for most of these pigs, there's a rapid decrease in respiratory rate down to respiratory arrest with about 20 to 50 seconds after the injection of fentanyl. And that sustains for a while prior to naloxone being given. This is without our drug reservoir first. So we gave naloxone to these pigs. And you notice that we are able to recover the pigs. Similarly, there's a decrease in heart rate is what we observed that we'll talk a little bit about. Is kind of coupled with the respiratory rate of these pigs at a SAT of FiO2 of 100%. And this starts to give our thinking around maybe there's a fusion of different sensors that allow us to distinguish other medical events. For example, sleep apnea. Sleep apnea, we know, also causes respiratory depression and has been a common thing that has kind of confused these sensors before. But is there a way for us to kind of couple the two parameters together with these sensors to start to understand an overdose event? Interestingly, we also had several pigs that were given fentanyl at the same dose, but for some reason, we think probably metabolic reason, they experienced a much slower onset of respiratory depression. And so you can think of these two cases as individuals who potentially are opioid naive or haven't used for some time or exposed to fentanyl for the first time, right? This is the group that we see a lot clinically who overdose and either die or are reversed with naloxone or see us in the emergency department. And then we have individuals who maybe have a history of use, who use and potentially kind of sink into this dangerous space where they're hypopneic, but not completely having a respiratory arrest. But even in those groups, you can notice that there's change in heart rate that is kind of mirroring the decrease in respiratory rate in those individuals. Um, and by individuals, I mean pigs, not humans. And so this is on a FI2 of 100%. And so, the big question that we thought was what happens, is 100% oxygen essentially decoupling the respiratory rate and heart rate on these pigs? And so we did a second series of animals where they were intubated, sedated, maintained an ISO at 100%. And then these pigs here were administered fentanyl. And once the fentanyl was administered, we turned off the 100% FiO2 and maintained them on a FiO2 of 20%, which is essentially maintaining them on room air. Once again, you see in these groups that these pigs rapidly, once you give them fentanyl, this T1 is the time to rapid kind of respiratory arrest from the overdose event, and you can see that heart rate kind of tracks and moves a little bit in concert with the respiratory rate. And as you expect, the SpO2 kind of is a lot, kind of slowly trails after that. These pigs also had arterial lines, and so this is the blood pressure from the A line. And then, so these are pigs that kind of took some time to overdose. And then we also had pigs who rapidly overdosed. And you can see that there's a similar kind of series of events where the respiratory rate goes to zero, but we see a concomitant decrease in heart rate, a more marked decrease in oxygen saturation and blood pressure. And for a lot of these pigs at this time, we actually assisted their ventilation and turned back on their FiO2 because we did not want the pig to completely die because there are other experiments going on. And so this suggests that, that potentially the use of heart rate and respiratory rate together in a sensor fusion algorithm might be able to help us easily distinguish opioid overdose from other events. And so we started to characterize. I think we're used to as emergency physicians and those of us who are toxicologists, kind of thinking about respiratory depression or hypopnea and associated, hypoxia and the indications for naloxone from a clinical standpoint. But our question was, by the time you have onset of hypoxia, it's been probably too long, and you want to reverse these individuals earlier. So, what are other parameters that we could potentially start to use? And so this is our series of about this is I think 29 different pigs, and this is their kind of overall collated into two groups again. This is the group that kind of took some time to overdose, and these are ones that rapidly overdosed in terms of defined by a decrease to respirator of zero within seconds after the fentanyl administration. And we tried to categorize individuals, the pigs, into the number of cases and the magnitude of decrease in their heart rate HRV, the heart rate variability, as well as their absolute beats per minute. And this showed us that there was a little bit of a latency in the decrease in heart rate that also kind of mirrored the decrease in respiratory rate. In pigs that rapidly overdosed, we saw that those pigs essentially had a rapid decrease in respiratory rate because they overdosed, and then the heart rate would start to trail. And there was about a change of about 5 to 10 beats within those first seconds. And in other pigs where there was a slower overdose, but you potentially will want to reverse that pig because of hypopnea, you saw that first there was a decrease in heart rate that was followed by the decrease in respiratory rate. Here on this side, we show that pigs that were maintained on 100% FiO2 and room air all had kind of similar. Obviously, the ones on room air had a greater kind of magnitude change, which allows us to think of heart rate as a potential piece of the sensor fusion algorithm here. And so as we kind of think more towards that, this is another kind of visualization of the animals. And this is the onset to respiratory, this is the onset to bradycardia. So a delta of about 10 beats per minute. And we can see that there is kind of a consistent decrease in heart rate associated with the overdose event. We also looked at skin temperature as well, and we also noticed that with the onset of kind of fentanyl administration, skin temperature also decreases as well. But that's a more difficult parameter to measure. It can be influenced by other environmental factors. So we decided against using that as part of our sensor fusion. Um, and so the other part of all of this is we talked a little bit about power budget. And so one of the questions we had was, all right, so now we have a potential algorithm where we might use the heart rate, so using ECG and the PPG sensor, um, and also respiratory rate, which is can be measured through the IMU, which is the accelerometer. But how do we maintain battery life longer than a few days, given the kind of the power budget that we have? And so here you can see that when these sensors are active in these blue columns, there's a large amount of energy that's used to kind of keep them up and active, but you can leave them in an idle mode or what you might call a sleep mode. If you have an Apple Watch, you know that that's what your watch does to save battery life. It turns it on every few seconds. And so we were able to kind of figure out kind of the parameters around how much decrease in sensing frequency we could accept to increase battery life. So we did some modeling over looking at accelerometer. So the IMU is probably the least power hungry, and so that started to become the most important piece of the initiation because we figured if you can leave all the other sensors in sleep and just turn one of them on, we might as well turn to one that generates the least energy. So this is the IMU or the accelerometer. And you can see by as you increase the sampling frequency, obviously the battery life decreases. But if you get a sampling frequency of 10 hertz, which is basically looking at 10 samples per second, you can still have a battery life of about 20 some days. So this is with the microcontroller. So this is the onboard computer to sense the data. So we're still able to get about a 20-ish day kind of battery life if you leave just the IMU on. In addition to that, the other piece was you may have seen this coil on the device, but this is a wireless charging coil, and so we developed kind of a magnetic charger that you could put on the skin. And so this is an animal experiment with the implanted device, and then by placing this charger right on top of the skin, on top of the device, you demonstrated that you can generate enough amperage to essentially recharge the device. So here we're starting to think a little bit about, an individual that theoretically you implanted the system on over the course of about 20 days or so. If they came back to clinic, you could spend some time recharging the device while you potentially talk to them about their opioid use. And so based on all that work, we put together this sensor-based tree. And we talked a little bit about this, that we wanted to use the lowest energy consumption device, which is the IMU or the accelerometer. And based on parameters there, it would sequentially wake up different sensors to confirm the onset of an opioid overdose. And so if the IMU senses a decrease in respiratory rate, then it would wake up the PPG and ECG, which together would confirm that there's a change in the heart rate. And if that happens, then it would basically trigger a rescue of the system. And the system, we created an alarm. So if the individual was indeed sleeping or something else and they were to overdose, they were able to kind of turn it off. And if not, then it would administer naloxone to the individual. And so this is the pump that we developed. I'll see if these videos work, but this is essentially a piston pump that uses a DC motor and allows you to kind of spray naloxone into the subcute space. This is looking at the longevity of the pump. So we filled the pump up, and after about a month, we were able to actuate it every 10 days and have a consistent amount of naloxone. The concentration within was stable under kind of an implanted condition, and the PK looked very similar as well. Oops. So there you have it. So that's our device. It's a series of, I think, different sensors that it's a novel kind of strategy, I think, to think about opioid overdose. It gives us some insight into, the different kind of physiologic parameters that may be happening proximal to the overdose event that we clinically may not make much sense or be necessary for us, but as a way to make a rapid decision for an implantable device has been proven to be pretty helpful. These are two different pigs in two scenarios with the implanted device with the onboard sensor algorithm. And so you can see in the red line, the dotted blue line, this is the administration of fentanyl. And so this is an implant device in the pig with a naloxone reservoir. And you can see that it detects in the rapid overdoses there's a decrease in respiratory rate and then a concomitant decrease in heart rate, which triggers the system to administer naloxone. And we're able to recover the pig after several seconds. And similar with a slow overdose, that the sensor fusion can still kind of determine that there is a kind of a bar at which naloxone is probably useful for those individuals who kind of have used enough to slowly kind of overdose themselves. And so that's the overall system. Right now, there's I think much more work to be done, but essentially, upon the overdose event, we're able to kind of detect, the system's able to detect and then administer naloxone in about 80 seconds, so about a minute and a half. Not bad, could be better probably. And then after that, we hope that the individual would recover, as our pigs did after receiving naloxone. And so I think some of the lessons we learned around integration into clinical care, where we tried to develop a device that potentially could be used on the office setting, so a bedside procedure with local anesthesia. Um, you could potentially discharge somebody home with a device like this that which will allow us to monitor for overdose. Obviously, the data would be recorded, and that could be reported to stakeholders within the individual's care, whether it's friends and family or their clinical team. And in the event of overdose, hopefully reversal could occur, allowing this individual to kind of survive and provide kind of real-time harm reduction. And then in follow-up visits, we did create the ability to wirelessly recharge the device. The naloxone reservoir has a little bumper, so you could refill it with the 27 gauge needle. And we have demonstrated that that's doable in a survival setting on a pig. And potentially you could review findings with your patient. And so hopefully this work is interesting to some of you. It demonstrates that an implant could be potentially a novel strategy to present a closed loop system. I think the work in sensor fusion and understanding the power budget are key pieces to future innovations here. There's lots of limitations here, and so I won't pretend that this is ready for human use. Obviously, we're limited by the animal model and the ethical kind of limitations of studying opioid overdose in animals. And we have to recognize that opioid overdose does not occur alone most of the time. There's co-ingestants, there's adulterants, which may kind of change the physiology and change the way we think about this. And finally, I think there's a huge need for what we're trying to do now is to engage the community and understand more about the human factors. And our plan is hopefully to move into a human trial in the next year or so. So thank you all. Thanks, Alex, for inviting me. And also thanks to we have a large team of veterinarians and drug delivery experts at MIT who worked with us. And thanks to our funders. That's all I have.
We're all clapping. Thanks so much, Peter. Innovative approach to combating opioid overdose and very novel, super interesting. Open it up here for questions from the group. You can either raise your hand or just start talking. I'll try to moderate. I had kind of a comment and a question to get us kicked off, which is, it seems like if you could somehow get an accelerometer to determine the postural tone of the individual, and then couple that with the delta change, delta decrease in respiratory rate, that seems like the best way to prevent false positives. I don't know if you looked into accelerometer, if you're able to detect if someone's lying flat or standing up.
Yes, you definitely can do that. In the pigs, we weren't able because they were all anesthetized, so they were all lying flat. And so, I think one of the things we're trying to work through is how we could potentially do this in an ambulatory animal setting. So could we implant the device and overdose a pig in a survival setting to kind of understand those parameters? But that's the limitation right now, and that's what we need to do in the future, I think.
Awesome. Jean Marie, you got your hand up. Welcome, by the way.
Hi, Jean Marie.
Hello. Hi, everybody. Nice to see you. Amazing work, Peter. Hello to everybody else. Uh, this is great. I have so many thoughts and questions. You've probably done this, and I probably just haven't read it about feasibility and acceptability of people. I also joined a little late of people wanting these devices. I know there might be a spectrum, but I'd imagine you'd find a cohort of people who would want them. Um, I know I was at ASAM last year, and there was a group that actually is somewhat related to Penn Health Tech, who created a device that monitors like a Apple Watch, and actually, I guess it's the Apple Watch, but it also has like a transcutaneous little something that sits on their shoulder that can inject naloxone, but they have actually been able to pilot it with people in Camden who will do the monitoring part, but will not don't want the naloxone injection. So they're currently getting data on how frequently people, hypoventilate or have near, respiratory arrest or whatever, and even maybe have, rescue from bystander naloxone or something. So they're collecting data. So it's kind of a feasibility trial. That's one question. And for the sake of time, my other question is, I don't know about the characteristics of naloxone, but I'm sure funders would say, well, what if, there's not enough naloxone? They wake up, but then, they go out again because it's short acting. Has anyone considered like putting buprenorphine in there or, something else that would be longer acting and, um, sort of treatment initiation, skipping the whole naloxone step?
No, great questions, Jean Marie. I think the Philly group is Alexis Roth's group, right? From Drexel, that's been doing some of that work.
I know, I want to say Jeremy somebody is an ICU. Maybe Jen remembers him, an ICU person at Penn. And maybe it's not Jeremy. I could look it up. I don't
Yeah.
think it's Drexel though. But
Oh,
the guys I met at ASAM were, I don't know, already at the like dissemination. They were not related exactly, but it was like a health tech accelerator program.
yeah. I mean, I think the issue with a lot of the wearable naloxone injectors is the speed at which naloxone is injected is slow. And the other issue is that for all of us who do subcutaneous injections, you get leak of drug outside of the
Mm,
skin, and so you may not get that full dose. And we had experienced that earlier with our device, and that's the kind of the rationale for the implant and the direction. We're doing some extra work now, thinking about how we can create other types of pumps that deliver drug kind of deeper into the tissue or intramuscularly. But they cause a lot of pain, although you could argue somebody who's overdosed,
mhm.
pain may not be the biggest issue for them at that point. But these are great questions and definitely things to think about, I would say. Regarding the buprenorphine, I think we do have the ability to ultra concentrate naloxone. So this demonstration with is a single 10 milligram dose, but we know that the pump was designed so that it takes minimal energy to kind of rapidly deliver, and we can deliver 10 milligrams over less than a second on this. And so we can ultra concentrate. We know that naloxone is pretty stable even at 97 degrees. And so one of the options may be to ultra concentrate and allow the pump to deliver more than a single dose over time. But the question of buprenorphine is really interesting. And also an acceptability question for patients. Yeah.
Yeah.
Could be your next
Good.
grant. John
Uh,
Schimmel.
if only.
John, I think you're next. John Schimmel.
Yeah. Hey, Peter. Thanks for this
Great.
talk. Fantastic work. A few questions and thoughts. During the recharging process, are there any thermal concerns?
Not that we
Doesn't seem to heat
found.
up under the skin or anything.
Not enough to cause a burn.
And then I'm wondering if you're ultra concentrating the naloxone or any other medication you might use in the future. Um, if you ideally get this towards FDA approval or clearance at some point, would you separately need to be compounding this naloxone, or would you be going for an additional sort of IND for a new labeled concentration?
Yeah, that's a good question, John. So, I mean, we are planning to try to push this through. And so I think, you could think of this as a drug device combination product, where we'd have to demonstrate safety and toxicology associated with drug, which we hope we don't have to do, or we can do easily because it's existing powdered naloxone that's just ultra concentrated. But these are kind of, this is why we're years away from a human trial. Um, yeah.
Thanks. And my last question, have you guys considered, I don't know what this would look like, but any type of warning or notification to the patient that, hey, the injection is coming, whether it's like a little 2 millivolt zap or something like, hey, in 10 seconds, start breathing or it's coming.
But yeah, so the device has a onboard buzzer that kind of vibrates under the
Oh,
skin that you can just slap and turn off.
uh-huh.
But ideally, it's Bluetooth linked to a smartphone, and so you could also actuate. So theoretically, if you were sleeping, and that's why your respiratory rate was low, and the device somehow decided you were overdosing, you would have the ability, at least a chance, to wake yourself up and cancel the alert.
Cool. That's what I was wondering. Thanks.
It's like in Ghostbusters when Venkman was doing the shock, warning them. Eduardo, you're next.
Yes, no, that was really interesting. Just a couple of things about the pharmacology, like, and again, you obviously don't need new alternatives because you have done a lot. Is like, obviously, nalmefene is available, which is more
Yeah.
potent and more long-lasting than naloxone, so that would be an interesting thing. And the samidorphan, which is interesting, that's the one that it was an opiate antagonist for other reasons. It was made by the company called Alkermes, and now it's in a mixed formulation with olanzapine, but it's also a very potent mu antagonist. So your tool would be maybe a better pharmacological tool. And then the other one, just I used to work in monkeys, and with monkeys you couldn't do an actual a full overdose, but there's people who do a lot of opioid behavioral pharmacology who've done respiratory depression, and they have a lot of experience with, chronic IV respiratory depression, and the monkeys are awake. So in terms of modeling, that would be feasible. And of course, you could have like, partial respiratory depression as a model, not a full apnea. But those things are feasible. Some of them are actually at Harvard. So yeah.
Great, thanks.
All right, Maddie, you're up.
Hi, Peter. This is fascinating and really was really interesting to hear about. So thank you. I was curious, and I don't know much about like the workings of these devices, but I know obviously the wearable devices can contact, like emergency providers. Is there any option for that with the implanted device? Like if it connects to a phone, can it like alert an emergency provider? Just because I can imagine, obviously, if there isn't that there, that the patient's at risk for another overdose or just not seeking medical care.
Yeah, I mean, I think, that we kind of left the smartphone interface kind of open for, a future developer or anybody, but you could conceivably think about that. You could integrate a radio transmitter into the device itself, but there would be issues with the power budget there. So ideally a phone or something like that.
Peter, how would you would you kind of envision this as a prescription or something that's available commercially? Like where's the future of this? Like, let's say that it works. I assume that the measurements are correct and that you've got a hyper concentrated solution that works and is stable over time, which it sounds like it is. So it's probably feasible. Like what's the end game?
Yeah, I think it's a medical device that is prescribed. The kind of our early concepts of this were people who are in like bridge clinics or early MOUD treatment where risk of overdose is high, and so this could be as implantable system for the first month of treatment since it's got a battery life of 26 days. And so you could at least have some protection. We thought about it in the chronic cancer pain population where, overdose is a potential thing and where rescue might be important. And of course, like other devices, there's always kind of the market of court mandated kind of, monitoring because, now that if we had an implanted device, I think one of the values is that while it would potentially reverse overdose, it could provide contextual information for clinicians so you could have better conversations with patients, looking at potential near fatal overdose or, reversals that occur during the interim between clinic visits to kind of coach people through, what happened, consider other kind of options for treatment as well. And so I think that's where it goes. I don't think it's, I wouldn't see somebody buying this and implanting it in themselves, obviously. I think this is, hopefully something that's prescribed.
Any other questions or comments for Peter? All right. Well, thank you so much, Peter. This was inspiring. We can't wait to see what happens next with this, and we'll obviously be following along closely, and we are happy to collaborate with you.
Yes, love it.
So keep us in mind. Yeah, so this was incredible. Stay tuned. We're going to try to do these. They probably won't all be as incredible as this one, or Jean Marie's or Eduardo's, but we're going to try to keep up a high level of excellence here with these, maybe once a quarter. And if you have any ideas for speakers, or if you want to speak again, or if you want to talk, feel free to just reach out to either myself or John Berger. John, you don't happen to know when the next meeting is with the lecture series, do you? Offhand? No pressure.
Not offhand, but our next meeting is October 30th.
Awesome. All right, so we'll send along a note, and thanks everybody for being here. Thanks again, Peter, and have a great rest of your day. I'll give you 10 minutes back to your schedule.